My name is Ashley Tucker. Will be your host this evening, and I'm so excited to welcome Dr. Jennifer Liao. She will be giving us a wonderful webinar on systemic diseases and scleral lenses. So Dr. Jennifer Liao is an assistant professor of optometry and attending optometrist at the New England College of Optometry. She earned her doctorate of optometry with honors from NECO and completed a residency in cornea and contact lenses the following year. Prior to returning to NECO, Dr. Liao practiced in Toronto, Canada as the Director of Contact Lens Services at the Vision Institute of Canada. In 2015, she co-founded the Therapeutic Contact Lens Clinic, a referral contact lens clinic at the University of Toronto's Health Network for patients with irregular corneas and severe ocular surface disease who failed with previous treatment options. She was also an associate optometrist at her childhood optometrist private practice, where she provided primary care and myopia control services. Dr. Liao is a fellow of the American Academy of Optometry and Scleral Lens Education Society. Welcome, Dr. Liao.
Thank you, Dr. Tucker. Thank you for that introduction. And let me just share my slides here. And yeah, thank you to the Scleral Lens Society, Maureen, Helen, for putting this together in such an organized way. To my colleagues, Rob Ainsley, president of the Scleral Lens Education Society, for the opportunity to speak. It really is such an honor to be here. Before I begin, I just wanted to share some disclosures with Boston Sight and Cooper Vision, who I think are most relevant to this lecture. So when it comes to the discussion of systemic diseases and scleral lenses, I think it's important that we understand how scleral lenses are today. Specifically, scleral lenses today are gas-permeable contact lenses, usually of higher decay material, and this allows these lenses to be worn for longer periods of time and allows for healthier wear because the oxygen can get to the ocular surface and maintain normal physiological function. Modern scleral lenses also rest in the sclera, and the goal really is to not touch the cornea. And this allows scleral lenses to fit over markedly irregular corneas and also allows for more comfort, especially as compared to corneal GPs. Modern scleral lenses are also filled with saline, and this allows for a constant fluid reservoir between the posterior lens surface and the corneal surface, which does two things. It neutralizes irregular astigmatism on that surface, but it also protects that ocular surface from any desiccating effects from air exposure. And finally, modern scleral lenses tend not to move on the eye very much, and this acts as a form of protection of the ocular surface from any sort of mechanical forces, especially from blinking. So these characteristics of modern scleral lenses ultimately make them very effective in managing a number of different conditions, which generally can be categorized into two main categories: distorted corneal surfaces and ocular surface disorders. When we actually look into the types of conditions that can cause distorted corneal surfaces and ocular surface disorders, we can see that the conditions are numerous, and many of these actually have systemic disease origins. This chart here was actually put together by my colleagues at Boston Sight, and I find it very, very helpful to understand really the type of conditions that can cause these two major things on the ocular surface. So we know that from numerous publications that scleral lenses are very effective at managing both ocular surface disorders and distorted corneal surfaces by providing comfort, with visual rehabilitation, and also rehabilitation of the ocular surface. But what I want to be able to highlight today is that scleral lens management of these ocular conditions is not independent of the systemic diseases that cause them, and how we, as scleral lens practitioners, should be aware of how our patients' systemic conditions can impact their scleral lens management. So there are some ocular conditions that have been reported to be well indicated for scleral lens management, often because these conditions tend to not be necessarily very successful with medical or surgical interventions. And for many of these conditions, they include dry eye disease, exposure keratopathy, neurotrophic keratopathy, and limbal stem cell deficiency. And clinically, these conditions don't typically present independently of each other. But for the purpose of today, we will be discussing each of these conditions individually and dividing them into their systemic causes, understanding the clinical manifestations, how scleral lenses fit into their management, and ultimately I'll be discussing a case for each of these so that we can better understand how systemic diseases play a role in our management of all of these conditions. So we'll start first by discussing exposure keratopathy. So what causes exposure keratopathy? It can be from paralytic causes such as neurologic causes like acoustic neuromas or a Bell's palsy. It can be from autoimmune conditions such as Graves' disease, causing the eyes to become more proptotic. It can be anatomical, such as nocturnal leg ophthalmos or from eyelid colobomas. And it can be iatrogenic, which means that it's caused by some sort of medical treatment, typically post-surgical, such as blepharoplasties gone wrong or from trauma. Clinically, what we see from exposure keratopathy on the milder side is exposure staining on the cornea and the conjunctiva, typically on the lower 1/3 of that cornea. Long-term exposure causes the tissues to start to break down and not function as well. And this is when we start to see more edema and especially more chemosis in the conjunctiva. This is typically associated with hyperemia, and long-term, we can start to see corneal neovascularization, corneal thinning, and the biggest concern with corneal thinning and an unhealthy ocular surface is some sort of ulceration, which is essentially thinning away of that tissue. So managing exposure keratopathy can really vary depending on the severity of that exposure and the long-termness of that exposure, but typically we're looking to lubricate that surface, and we can do so by lubricating with artificial tears. We can also anatomically try and fix that eyelid, such as using a lid weight to bring the eyelid down lower to cover that part of the ocular surface that's not being protected. Or we could use something like a scleral lens as a tool to cover that ocular surface and protect it from that from desiccation. And in very severe cases, we can actually sew the eyelids together in a procedure called tarsorrhaphy. So scleral lenses have a role in exposure keratopathy, and I would argue that I think in more long-term cases of exposure keratopathy, it is becoming more and more of a sought-out option for our patients. But I actually wanted to start with this case of a 45-year-old female who was referred to my clinic for exposure keratopathy secondary to workplace trauma. She came in and she had a scarred upper and lower eyelid tissue. Her left upper eyelid only provided about 3 millimeters of movement with blink, and the bottom 7 millimeters upper ocular surface was actually exposed. When she came to me, she was using quite a bit of preservative-free artificial tears throughout the day, and she was using ointment at nighttime to try and maintain the ocular surface. This is not her, but it is actually a good image of really the type of scarring and the type of tissues that her eyelids were functioning with. So she had lots of reconstructive surgery on her face and on her eyelids. She was actually a police officer and was attacked at work. And so for her, it was not just a very traumatic experience for work, but also a traumatic reconstructive experience as well. And she was really miserable using artificial tears throughout the day and really was seeking another option. So for this patient, our goal in our scleral lens fitting to help with exposure keratopathy was to try and maximize the coverage over the ocular surface. So we're really thinking a larger diameter lens here, and to really help with the functioning of that surface of her eye. So really helping with that non-functional blinking mechanism, and using the lens surface to help with considering a lens that would allow for better wetting because that eyelid is not helping distribute the tears. So when I'm considering this, I'm thinking of a lower wetting angle lens material and also potentially the need to use artificial tears over that lens surface. So here's an example of what an ocular surface can look like outside of the area where a lens is not covering. So you'll see where the lens junction ends, where the lens edges blend, and then where the ocular surface is exposed. For this patient, she was fit with an 18.5 millimeter lens, which is one of the largest diameter lenses I had in office. And she was immediately thrilled. She immediately felt increased comfort and more stability in her left eye vision. And with over-refraction, she was able to achieve 20/20 vision. And I wanted to share this case because for her, she had told me that she always told her doctors that she wished that she could just carry around a bowl of liquid to hold over her eye. And she was like, this is exactly what I was asking for. And I'm surprised that it had been years before I was referred for this. And so I actually present this case. I had first presented this case to ophthalmology because I felt like it was something that was very simple that we could do that was very life-changing for many patients if they only knew the options. For this patient, though, although it was wonderful for her initially, at her 1 month follow-up, she came back and she was really only comfortable wearing her lenses for about 3 or 4 hours. After that, her lenses started to feel sticky and her vision started to worsen. And she said that sometimes her vision also started to feel foggy at that time too. She was previously best corrected to 20/30, and when she came back, she was 20/20, excuse me. And when she came back, she was now seeing 20/30. So her lenses look like this at her follow-up, which is what we call pore surface wetting. So the surface of that lens is becoming hydrophobic because there isn't a good distribution of tears over top of that lens throughout the day. And as the lens becomes drier and drier, we start to see these hydrophobic spots develop. So how I explain this to my patients is essentially the dryness on the eye has now been corrected with this lens, but now we're seeing dryness on the surface of the lens because the dryness is still there because the eyelid is not functioning. Things that we can do to help with this is to manage any sort of dry eye disease and lid disease if possible, such as meibomian dysfunction, really focusing on any sort of contributing factors such as oils from makeup or lotions or on the plunger itself as you're using the plunger to remove the lens. Reviewing cleaning. So I personally do like using a peroxide solution or alcohol-based cleaner to help with the hydrophobic tendencies of these materials. And then if there's a lot of protein, Progent is a very effective protein remover that can be effective in a regular regimen for these patients to prevent these dry spots from forming. Changing the material to one that is better wetting typically helps. And adding HydroPeg is also something that can be very effective. So HydroPeg is a coating that you can put on a lens and it makes the lens more hydrophilic and more slippery. So here's an example from Tangible Science, which is the company that makes HydroPeg. This is a lens before HydroPeg and this is a lens after. So this typically will help patients such as this one where we're seeing this pore surface wetting after a short period of time. So ultimately what we did with this patient was we changed her material from Boston Equilens, which is what she started with, to Optimum Comfort. So that wetting angle would be a little bit lower, allowing for more tear distribution. Changing or being more specific with her lens care, changing to an alcohol-based cleaner at night and using a conditioning solution during the day. And then if needed, removing her lenses every 4 to 6 hours and reapplying and conditioning her lens and reapplying so that she can avoid these hydrophobic spots. Continuing with dry eye management, so her lid hygiene and using preservative-free artificial tears regularly over top of that contact lens to make sure that the contact lens stays as hydrophilic as possible. And with this, she was able to maintain good, stable vision with her Scleral lens at 20/15 and have a much healthier and stable ocular surface. So the takeaway from this relatively simple case is that a scleral lens manages the ocular surface, but the systemic cause of the ocular surface disease is still unchanged. So in this case, the scleral lens is protecting the ocular surface and allowing her to have a better quality of life and not have to depend on artificial tears throughout her day. But there were things in our scleral lens fitting that needed to consider the impact of this non-functioning eyelid. And by implementing these things, we could make her scleral lens fitting and her scleral lens management much more successful. So that's exposure keratopathy. The second condition we'll be discussing is dry eye disease. And dry eye disease, I think, is one that we see every day if we do see patients. There are a number of different conditions that contribute to dry eye disease, but most commonly, these conditions tend to be inflammatory. Autoimmune conditions such as Sjogren's disease and ocular graft versus host disease are on the list. post-surgical, post-radiation, and in a more severe side of the spectrum, Stevens-Johnson syndrome and toxic epidermal necrolysis also can cause more severe dry eye disease. So dry eye disease, according to Deuce 2, is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. That's a very heavy definition that when I break it down to try and understand how my scleral lens management falls in this, is that dry eye disease ultimately begins with inflammation, and that causes cellular breakdown, that causes the loss of homeostasis and physiological function of these ocular surface diseases. And so when we do have dry eye disease, it impacts the ocular surface tissues, which include the eyelid, the conjunctiva, the cornea, the tear film, and the lacrimal gland. And this homeostasis affects both a mechanical function, so our blinking mechanism, as well as physiological functions, such as the secretion of the tears. So when we're thinking about how to manage dry eye disease, in the same way that there are a host of different causes of dry eye disease that cause a huge range of presentation of dry eye disease, our management would reflect that as well. On the simpler ways of managing, especially mild cases, we'd be looking at lubricating the ocular surface and trying to retain the tear film on the ocular surface, such as using punctal plugs or moisture chamber goggles. If inflammation is flaring up or is becoming more of an issue that's causing the dry eye disease, then there are things that we can do to reduce inflammation, either through topical medication or with lifestyle changes. And if there's issues with the epithelium and the ocular surface tissue breaking down, then we can implement other tools such as using scleral lenses and perhaps even amniotic membranes if there is a case of corneal breakdown. So in our case here for dry eye disease, here we have a 57-year-old female who was referred to the contact lens clinic for red, irritated eyes in both her right and her left eye. It was so severe that she needed to wear sunglasses indoors. She was interested in her candidacy for scleral lenses because she had tried a host of different things that were not successful in the past. Her medical history was positive for rheumatoid arthritis, and her current medications when she was seeing us was taking Xeljanz, which was recently switched from taking methotrexate. Her ocular history was severe dry eye disease, mostly secondary to her rheumatoid arthritis. We know that when she has flares in her rheumatoid arthritis, we see a flare in her dry eye disease as well. She had tried punctal plugs in the past, and there was no improvement in her symptoms. And in the past, she had tried topical steroids as well as topical cyclosporin and lifitegrast, also without success. She's been very diligent with her lid hygiene, doing hot compresses nightly and using artificial tears regularly, which provides some relief. But ultimately, she was looking for an option to try and improve her ocular comfort and her quality of life because she was a very active 57-year-old female. When we looked at the clinical signs on her eye, we could see that there was a lot of inflammation. She had eyelid inflammation as seen in her meibomian glands and also on her eyelids with blepharitis. She had conjunctival inflammation seen with hyperemia and chemosis. And on her cornea, there was corneal inflammation seen with grade 2 superficial punctate keratopathy. So in this case for her, because this patient had dry eye, we wanted to consider in a scleral lens, a lens diameter that would really cover more of the ocular surface to try and protect that ocular surface and lubricate that ocular surface as much as possible. Again, we were also considering a low and wetting angle material to help the tears distribute and help the patient's comfort. So we decided to trial a 17mm scleral lens in the office. And for this patient, she had almost immediate relief and comfort, and she was very happy. So we proceeded with the contact lens fitting. We ordered the lenses, and we achieved what we thought was an excellent fit, and we dispensed the lenses. So we saw her back for a 1-month follow-up, which is when I would typically follow up a patient who's happy. But 2 months later, she came back, and her eyes looked like this. So this, to me, does not look like a very good fit. And so we were kind of scratching our heads and wondering what happened. This patient came back and her eyes were red and they were irritated, both eyes. We saw what we graded as grade 3 diffuse injection, conjunctival injection specifically, and the lens suddenly was not fitting great. We saw peripheral blanching 360 in both the right and the left eye. And so this led me to ask what had happened, because when we saw her 2 months earlier, everything was great and she was happy. Well, she told us that she had a flare in her joint pain and joint pain in her hands about a month ago when she saw her rheumatologist, who changed the dosage of her medications. Because this patient didn't need to wear her contact lenses, her scleral lenses, there wasn't a risk in her of her ocular surface really breaking down if I were to take away her scleral lens wear because of this flare. In her management, we decided to discontinue her scleral lens wear and to initiate a topical steroid to reduce some of that superficial and that ocular inflammation. So we initiated use of loteprednol 0.5% 4 times a day in both eyes for 2 weeks. And we also got in touch with her rheumatologist and explained what we were seeing to make sure that we were both in touch to understand how her rheumatoid arthritis was and how her condition was and how it was managed.
Hi, everyone. So just give us a moment. We're going to try to get Dr. Liao back. I hesitated because I didn't know if it was my internet or hers, but just give us just a moment. There we go. Sorry about that, you guys. So I am so sorry. We're trying our best to get Dr. Liao back on. Our technology is failing us at the moment. So hopefully we'll be able to get her here in a moment. But let's take this opportunity to ask any questions that you may have. I will do my best to answer anything that I can. And I think we'll get some of my colleagues from the SLS to hop on as well. Someone has asked, are these slides available somewhere? We can certainly make them available to you. The webinar, we will, I'm sure, edit it and put it back together. It will be available on our YouTube channel. Someone is asking, since we can't get low bob anymore, from your understanding, which is true, what other solutions do you recommend? I personally use Boston Sim Plus in my practice quite a bit. Most of the Boston products are a great replacement for low bob. Keep the questions coming, guys. Do we need a QR code in the OE tracker app? Yes, you will need a QR code. We will provide that QR code at the end of the webinar. Granted, we get it back up and running. Someone's asking me to repeat about the Boston product. So we have a question here specifically about low bob not being available anymore, which it hasn't been available to us in a while. Somehow patients still can get it. I don't know where or how, but I personally use Boston Sim Plus. That's a really great just multi-purpose solution. But the whole line of Boston products, the advanced and the conditioning solution, are pretty comparable to the low bob family of products. I'm sorry, a lot of these are specific to Dr. Liao's lecture, so I'm hoping she'll get back on and address some of these.
My apologies, Dr. Chucker. We're still trying to see if we can get Dr. Liao back online. We don't know what technical issues came up. Our apologies. So if you could hang in there just one more moment.
Sure.
In the meantime, if anyone has any questions they want to drop in the chat or Q&A, maybe Dr. Tucker could answer a few of those while we get Dr. Liao back online.
One person had an interesting question. Would you say that this is that a lot of these cases are multidisciplinary in management? I absolutely 100% agree with that. So, you know, we can really do our best as the eye care provider, but a lot of these conditions, especially some of the cases Dr. Liao was talking about tonight, are systemic conditions. So we can't really do everything with the management of the patient's systemic the repercussions of an undiagnosed or untreated systemic condition. So absolutely, this would be a multidisciplinary part of scleral lens care for sure. In my practice, I do all of this, the scleral lens fitting, but I have an associate that does all the dry eye management. And I know a lot of those go hand in hand, but for me, the dry eye part is just more than what I'm willing to deal with. And I'm so fortunate that I have someone on my team that can manage the nitty gritty dry eye component. think we may have Dr. Liao. There we go.
Oh, I'm sorry. I didn't know that I had disconnected from Zoom.
Oh no. Okay, I'm gonna let you pick back up. I'm going off camera.
Okay, thank you. I actually am not quite sure where I left off, but I will continue on from my case of neurotrophic keratopathy here. And if there are any gaps in my discussion, I'm happy to fill that in. So I apologize for that. I have not had that happen. And this was, I kept going, not realizing that I had been disconnected. So I was discussing neurotrophic keratopathy and the importance of assessing the eye and really looking at your clinical findings rather than depending on your patient's symptoms, because our patients with neurotrophic keratopathy typically do not have much sensation on their cornea and really aren't reliable in the feedback of how their lenses are feeling or how their eyes are feeling. So in this case here, I have a 72-year-old male who was referred to our clinic for a scleral lens refit in his left eye. He came to see us because he felt that his vision was poor now, and he'd like to be refit in a lens with goals to try and improve the vision in his left eye. He brought the parameters of his habitual scleral lens with him, which he was actually very happy with. He wore his lenses full time, on average about 16 hours a day, 7 days a week. His ocular history was quite extensive, and like many of our patients who may have an extensive systemic history, I oftentimes am getting really the summarized chunk at his last eye examination. So he has had a full thickness corneal transplant in both eyes, the first in his right eye in 2005, first in his left in 2006. He most recently had a repeat PKP in his left eye in 2015, and his corneal surgeon is closely monitoring that right now because there's concern of the viability of that graft long term. He's had a history of laser retinopexy in both eyes, secondary to type 1 diabetes that he's been diagnosed with for 58 years. And he's functionally monocular, so he functions really only with his left eye. His right eye does not have very good vision because of the retinopathy, because of his retinopathy. Currently, when he came to see me, he was on ocular medications of Muro to help with his graft swelling. He was taking a steroid twice a day and taking IOP lowering medications to try and control his eye pressure. He's followed regularly by cornea, by retina, and by a glaucoma specialist to make sure that all of these things are checked. And when he came to see me, his goal really was visual rehabilitation. So really trying to improve his left eye to function better. And he thought that having a scleral lens refit could help with that because his current scleral lenses were older. So his VA in his right eye was light perception and his left eye was 20/80. On first assessment underneath the slit lamp, I could tell that he had corneal edema. And in taking a look at his cornea underneath that lens, I could see that we had some corneal bullae. And you can see that here. So bullae is this outpouching of the corneal epithelium. So the epithelium is not tacked down to the basement membrane as usual. And you can see it when a scleral lens is laid on top because it now floats into that space, that liquid reservoir between the lens, which you can see here is this first black band, and the cornea, which is behind it. When I took a look at the lens fit, the fit of the lens was actually very acceptable. This lens had very good clearance across the entire cornea, and the peripheral curves actually aligned very nicely with the sclera. Because this patient had this unusual bullae, and it was my first time seeing him, and knowing that he was on IOP lowering medications, I wanted to check his IOP after lens removal. And to my surprise, I found 11 in the right eye. Even though the right eye wasn't visually functioning, it was still a relatively healthy functioning eye. It had 11 millimeters of mercury of pressure, but the left eye was 28. And to me, that was unusual because there was such a discrepancy. And so before refitting, I decided to refer him back to cornea for an assessment. Since it was my first time seeing him, I wanted to make sure his corneas really could be at a better state. And for now, I asked him to discontinue his lens wear if possible. And for his future scleral lens refits, we discussed the potential to put him in a material or design a lens in a material that was of a higher decay so that the tissues underneath that lens can have the best physiological function with oxygen, and also to try and design lenses with channels to increase tear exchange to the ocular surface. And if a scleral lens really wasn't a viable option, we also discussed the potential for a corneal GP lens refit as well. So 6 months later, which is when he came back to see me, he had seen his glaucoma specialist, his retinal specialist, and his corneal specialist, who all mentioned that his condition was stable. When he saw me this time, his left eye was 2200 in vision, whereas previously he was 2080. And so I took a look at his eye again. And when I took a look at his lens fit, again, everything there looked really good. There was acceptable clearance, and the peripheral curves of the lenses looked very well fitting on that sclera. And there was improvement in the corneal signs, so not as much edema. There was no bullae seen. I removed the lenses and checked IOP again, and this looked a lot more normal here. But after removing the lenses and taking a look at his cornea, I could see that there were 3 epithelial defects along the graft-host junction, and there was some late diffusion into the stroma. And this patient was completely asymptomatic. He had no idea that his cornea was not healthy, or he wasn't feeling anything on that surface there. And he wasn't feeling this because he was neurotrophic. And so in this case, the biggest thing I wanted to share here is that when we're managing our scleral lens patients, we need to consider the impact of the disease complications and the impact of the medication side effects, the impacts of the side effects of the medications that they're taking to their eye. So in this case, the lens fit in the VA really didn't tell us the whole story for this patient. Seeing bullae on his cornea really was what prompted me to check the IOP. And that is something that I would have wanted to address to make sure that we weren't trying to fit a lens on an eye that was dematous. And also knowing that the eye is neurotrophic, I really wanted to make sure that we were checking the eye carefully and assessing to make sure that there weren't any signs in the cornea that would keep us from being able to proceed with the scleral lens fitting. So this patient to this day still has not had a scleral lens refit with me. I had referred this patient back to his corneal surgeon to take another assessment of this cornea because we were seeing these epithelial defects, which I suspect were persistent epithelial defects that have been there for some time just based on their appearance. So these patients are certainly a lot trickier and really require clinical skills to make sure that the cornea and the ocular surface are healthy enough before we really want to fit a lens. The last condition that I'll discuss today is limbal stem cell deficiency. So limbal stem cell deficiency can have a number of causes. Congenitally, we can see this with aniridia, but we can also see this when we have mucosal tissue breakdowns, such as in OCP or in Stevens-Johnson syndrome and toxic epidermal necrolysis. We can see it as a consequence from trauma, such as from infections or from chemical injuries or just from physical injuries. And contact lens abuse is also a part of that physical, potentially mechanical physical irritation as well. We can see limbal stem cell deficiency also as a consequence from iatrogenic causes as well. So the limbal stem cells on the eye function as a barrier to prevent the conjunctival tissues from coming into the cornea, but also function as stem cells to regenerate the epithelial cells, or regenerate the cells on the cornea. So any insult to that and to the limbal stem cells would cause a loss of the barrier function and would cause conjunctivalization and ultimately corneal neovascularization and scarring, and what would end up being corneal breakdown and wound healing issues. And so our goal when it comes to managing limbal stem cell deficiency is ultimately to try and remove the insult so that we can prevent this downstream breakdown of the corneal surface and ultimately to prevent vision loss. When it comes to management, the first part of managing limbal stem cell deficiency is to try and protect the ocular surface. And this would be either by lubrication, but also scleral lenses can play a role here too. If we're seeing epithelial defects, then we'd usually want to manage these persistent epithelial defects by preventing infection and promoting re-epithelialization. And especially if all treatments are ineffective, or if the condition continues to worsen despite all of these treatments, then limbal stem cell transplantation can be considered as well. So in this case, I'd like to highlight this case of a 29-year-old male who had presented to our contact lens clinic, who had a history of Stevens-Johnson syndrome that was diagnosed when he was 11 years old. His ocular history was significant for limbal stem cell disease, worse in his left eye than in his right eye. And he had a limbal stem cell transplant in his left eye actually a few years prior in 2016. His biggest issues ocularly was the number of symptoms that he was having and how much it affected his day-to-day. He had sandy, gritty eyes that were watery and they were burning and red. He had discharge, and when it came to visually, he would have difficulty seeing around lights, seeing a lot of glare, and he would see things that were distorted and blurred, which were causing frequent headaches. His goals really for coming to our clinic was to try and improve his comfort and to try and increase his function visually, rather than depending on just artificial tears, which is what he was doing to help him feel better. Incoming VA uncorrected was fluctuating. So he was about 20/25 to 20/40 in his right eye and hand motion in his left eye. He was taking a number of medications, so some that were immunosuppressive and more anti-inflammatory to help to control his SJS, and then also prophylactic antibiotic, and he was taking artificial tears prophylactically as well on his eye to help with his comfort. So this is how his right eye looked like at presentation. So you can see this very, very injected eye, and you can see this very extensive limbal stem cell deficiency and corneal neovascularization into the cornea. And I think this would explain why we were seeing some fluctuating vision. And in his left eye, when I first saw him in 2018, this is what it looked like. And by the time we were ready to fit him after insurance and after running around to try and get him back into the clinic, this is what it looked like. And so when it came time to refit, what we wanted to really make sure was to try and get that right eye refit, because that left eye with that symblepharon would not be a candidate for a scleral lens at that time. What we wanted to consider was what was going on in that right eye. He had limbal stem cell deficiency. He had severe ocular surface disease with trichiasis and keratinization of that palpebral conjunctiva. And so seeing that, my goal is to really go larger to try and protect that ocular surface. We were limited by symblepharon at the bottom corner of his right eye. And for him, we really wanted to make sure that we were maximizing DA because his ocular surface tissues were already compromised. So we wanted to make sure that we could get as much oxygen to those tissues as possible. What we decided to do was trial what I had in the office was the largest diameter of 18.5 millimeter. And for him immediately, his best corrected VA was 20/20. And he had immediate significant relief of pain and improved photophobia right in the clinic. After establishing an acceptable fit, we dispensed the lenses and we started with an average wear time of 5 hours a day, and he was able to increase that to 8 hours a day eventually. And so this patient was a really nice example of how a scleral lens was able to protect that ocular surface and help this patient go from this in November of 2018 to this 2.5 months later. He was much more comfortable. He was able to function much better, and we were able to reduce the pain and discomfort and stabilize his vision to meet all of his goals. So the next step for this patient was consultation for symblepharon removal in that left eye, and future fitting considerations in that left eye, and ultimately to also maximize optimal scleral lens wear time in his right eye. I wanted to share this case because in cases where we have very complex systemic diseases such as SJS that are long-standing and chronic, we want to make sure that we continue to be actively co-managing with other specialists to allow exploration for the best care for our patients. I didn't even consider potentially a symblepharon removal until I spoke with his corneal specialist. And it really was just seeing the success that we had with the right eye, and really given the age of this patient, all the things that he wanted to do, what we could offer him if we could just be creative. And so in speaking with his rheumatologist, in speaking with his corneal specialist, and then with an oculoplastic surgeon, this was the direction that we decided to go for him. And so I think from these cases today, we can see that when it comes to scleral lens management of these different conditions that are caused from systemic diseases, there's a host of different things that we'd have to consider outside of just the fitting of a scleral lens on the eye. And when we're seeing complications, especially, we really want to consider not just the complications that we typically see with a scleral lens, but also complications that would typically manifest from those systemic conditions that are causing the ocular condition in the first place. So with that, I'm going to wrap up the presentation with my finale case, which is actually one that I have presented with my colleague, Dr. Alan Kwok of Boston site previously. This was his patient, but I think it highlights very well this topic that we're discussing of systemic diseases and scleral lenses and how things really can take a turn, and we really have to consider all of the factors involved in what is causing these ocular conditions for our patients. So in this case, we have a 45-year-old female. She has graft versus host disease, which is an autoimmune inflammatory condition, secondary to stem cell transplantation in 2003. What graft versus host disease typically causes is this very severe ocular surface disease that manifests as dry eye disease. And for her, it was worse in her right eye than in her left eye. She was seen at Dr. Kwok's clinic and had PROS treatment initiated, and PROS is a very specialized scleral lens, in 2009. Her medications were Valtrex, an oral antiviral, and that was taken once a day, and a topical steroid once a day in her eye as well. But she had been actually managed with scleral lens for many years, from 2009 onwards. But in 2014, she presented to the clinic with complaints of discomfort and redness in her right eye and some recent mouth sores. So at this presenting examination in June 2014, she had this complaint of discomfort and redness in her right eye and these recent mouth sores. And on slit lamp, this is what was seen: a paracentral epithelial defect with smooth edges. And so the diagnosis made at this time was that we had this epithelial defect secondary to a GVHD flare. We know that graft versus host disease can have flares similar to Stevens-Johnson syndrome, like the previous case, and this can cause a very inflammatory response in those ocular surface tissues and cause these tissues to not function as well. And typically wound healing and epithelial wound healing is one of those consequences. So it made sense that we could see this epithelial defect after a GVHD flare. The treatment in this case was to initiate 12-12 wear with the PROS device, which means that this patient would be wearing a scleral lens during the day for 12 hours, and then changing that scleral lens and wearing a scleral lens at nighttime for 12 hours to make sure that it allowed for that protective function on the cornea and the ocular surface. To increase to the FML, so the topical steroid, to twice a day rather than once a day, and to increase the oral antiviral to twice a day as well, rather than once a day. What they found at the one-day follow-up was that this patient was not responsive to treatment, and this epithelial defect increased in size. So seeing that, they decided to add Zervan, so a topical antiviral now, and increased Valtrex to 3 times a day. And this time they decided to discontinue wearing the scleral lens at nighttime. So really just wearing the scleral lens during the day, avoiding any sort of complications with wearing a lens at nighttime. And the next day, they found that the epithelial defect increased in size again. So the concern here is that this defect is not responding to the treatment, but knowing that this patient was previously on FML, and we were seeing that this epithelial defect was beginning to increase in size, Dr. Kwok and his team decided to now increase the antiviral and to discontinue the FML so that we could reduce any sort of steroid that could be causing any potential opportunistic virus to cause this epithelial defect to worsen. And so they decided to resume wearing the PROS device at nighttime and to continue with the antivirals in case this is a virally caused, in case this defect is caused from a virus. And so what they found as they continued on and they knocked down the herpetic virus is that the epithelial defect eventually began to decrease in size 2 days later. And following that, 2 days after that, so after about 5 days of using the prescribed amount of antivirals, both topically and orally, that epithelial defect resolved. So I think this case does a very good job in highlighting how systemic diseases continue to be active, even as we're fitting with scleral lenses, and even if scleral lenses are historically very stable for our patients. And so it's important to make sure that we continue to be active again with the co-management with other providers, and to make sure that we're considering all of the conditions that could be causing these breakdown of the ocular surface and what could be causing complications underneath that scleral lens. So although scleral lenses are very effective, the ocular condition can be hugely affected by the systemic condition. So we want to make sure that we're checking not just the fit of the lens, but also looking at the systemic diseases and how it may impact our scleral lens management there. So although today we've broken down each of these ocular conditions to discuss how the systemic diseases impact the ocular surface and how scleral lenses can be indicated in their management, we know that all of these conditions do overlap in some way clinically, and all of these conditions can be impacted in multiple ways by different systemic conditions. And so although scleral lenses can be very effective at managing these conditions, and we can group them ultimately into both ocular surface disorders and distorted corneal surfaces, what we want to make sure is that we don't lose sight of the systemic diseases that are at the root of the causes of these conditions. And so when we manage our patients, the management of these patients' scleral lenses usually goes far beyond the fit of the lens on the eye. And it usually involves considering the patient as a whole and considering their systemic health, not just looking at the contact lens and the scleral lens fit on the eye.